So we also wanted to discuss the concept of the hypoxia plateau. And so this is essentially patients with a terrible condition or, something that is never going to allow us to oxygenate them and get their SpO2 up to an appropriate level. And so no matter what you do on scene, you're never going to get to that point. And so these are the patients that oftentimes, we walk in, they're hanging out something super low, like in the 70s. We break out the BVM, start BVMing them. We get a small rise in SpO2. We get all of our adjuncts in place, get them, sitting up, high flow nasal cannula going, get good end-tidal CO2 with every breath. And, they rise up pretty good, but then they just kind of stall out in the mid 80s, maybe high 80s, even low 90s at times. And there's nothing that we can do, no matter how hard we work. We're never going to get them up into, the 94 and above type range. And so that's okay. We're doing all of our best efforts for that patient. However, they are in a dangerous situation at that point, and it's not a safe intubation because they're actually already starting hypoxic before you even considered starting an intubation. And so this is where this concept comes into place. And so if we're doing max BVM ventilation with good end-tidal CO2 and the patient is persistently hypoxic, that's where the quick king comes into play. And so we'll crash in a king quickly. And so why do we go to a quick king, right? First, it's incredibly fast. So the second part is that currently in our system, we have a mid to high 80s first pass success with the king tube. Our first pass success is not that great yet for our endotracheal intubation, and certainly we're not doing 30-second intubations or even consistently less than 60 oftentimes. And so we can't move forward with a already hypoxic patient in a intubation that is not going to be a high success rate and also is simply not a safe thing for the patient. So placing a quick king is going to be where you want to go here. Don't forget about PEEP, or for your CPAP, positive airway pressure, or PAP. And so we may be really good about putting our PEEP valve on our BVM. However, we may just set it to 5 and forget about it. If your blood pressure is good and the patient can tolerate extra PEEP and needs it, don't forget to titrate that up. Take it to 10, take it to 15. Don't forget about that extra little maneuvers to get even better oxygenation for your patient during that. And remember, that may not just be while you're BVMing, it may also be on top of your endotracheal tube or your king tube, depending on the right circumstance. And so also for your CPAP, you got to look at the dial. And so look at that dial to see, is the flow rate I'm giving that patient the pressure that I'm actually getting out? And so if you're giving 15 liters per minute, you should be getting a pressure of 5. So if you're seeing like something in the 2 to 3 range, check your seal on your CPAP first. So that's going to be the most common thing where I'm giving the flow rate that should be appropriate and I'm just not getting the positive airway pressure back on this. And so check your seal, maybe tighten it down, maybe reseat it, and check that you're getting a good seal on your CPAP. And then once the patient's kind of getting comfortable on it, they're trusting you, they're not freaking out the minute you put the CPAP on their face, start progressively titrating that CPAP up as you need to. And be cognizant and continue to watch that dial so every time you titrate it up, that you're getting the pressure that you want from the flow rate that you're giving that patient. And so we really want to build good fundamentals right now on CPAP and utilizing it to its fullest, because in the next protocol revision, our plans are to be moving to BiPAP, or bi-level positive airway pressure. And so the BiPAP has an additional setting on it that adds a little bit extra complexity at that point, but can be an enormous benefit. So when I receive patients in the emergency department, I put them on BiPAP 99% of the time. And so our thoughts are, if we can bring emergency department care to the bedside of the patient out in the field, that's absolutely a great thing. And so when we looked at the protocol revisions that are coming up, we realized that it was going to be operational and economically feasible to be able to bring BiPAP out into the field. And so that brings in the concept of inspiratory positive airway pressure, which gives the patient a little bit of a leg up when they do some expiration, not just focusing on exhalation like your CPAP there. So again, just develop good fundamentals and troubleshooting and working through your CPAP now, so when we add a little extra complexity, that we can do even better. So remember that also that respiratory distress and respiratory failure categories are not static. You're not just stuck in one category or the other as you move forward here. And so a great example of this is your respiratory failure patient, right? the opioid overdose, they got the needle hanging out of their arm and the whole deal, and you start giving them some BVM ventilation, blow off a little end-tidal CO2, give them a little naloxone because they met protocol for it, and all of a sudden the patient's, have a great improved mental status, their respirations are picking up, they're no longer in respiratory failure, they're just requiring a little oxygen support with an under-breather or something like that. That patient is now moved over into that respiratory distress category. However, respiratory distress moving into failure is much more dangerous, right? They're on the downslope, they're going downhill. And so, great example of that is exactly your COPD patient. They've been breathing for 3 days, they're tiring out, we give them a trial on CPAP, and now we're seeing that hypopnea or those speed bump ventilations again. They're very obviously not ventilating appropriately. We need to take over their ventilation, start assisting them. So that patient is moving from that respiratory distress category into that failure type category. Let's talk about our goals again, right? So respiratory distress, basically we're getting that 94%, or we're getting that safe exit strategy where we're going to drop that quick King or that quick SGA in. And if we're in a COCV situation, we're going to go in and perform the cricothyrotomy if we need to. And so ultimately, when we've established our respiratory goals at this point is getting to a point where we can address the circulatory and then get moving forward. So you may have been asking yourself at this point, when do I intubate? Why have we not talked about that at all? And so we don't intubate yet because we haven't addressed the full picture of that patient. So to make a safe drug-assisted airway or eventually even an RSI type intubation, we have to cover both the airway and breathing, but also the circulatory portions to ensure that's going to be safe. And so this is a reminder, we have to resuscitate before we intubate. And so we have to get those circulatory goals appropriate and get our SpO2 appropriate range that we can, have a safe intubation where we're not going to have a patient crump or decompensate after that. So this is our HOP killers right here. So the HOP killers are hypotension, hypoxia or oxygen, and then acidosis or pH. And so these are the ones that set us up for failure after we go through our intubation, right? If we don't address critical hypoxia, we don't address critical hypotension, or we have a profoundly acidotic patient, that patient may end up crumping afterwards and going into a post-intubation cardiac arrest, or even, just dropping their blood pressure as well. And so A and B have addressed our hypoxia, or O, in this, but we need to focus on and take care of the circulation part and address the hypotension, and then by addressing both the oxygenation and the hypotensive part, we may improve the acidosis type picture on that patient as well. So covering the HOP killers is first. That doesn't mean, the entire time we've done a respiratory status that we've just completely ignored circulation, but we know that, the A and Bs are going to kill our patient far quicker than our C most of the time, and that's why it's in a stepwise order. All right, so now we're going to cover our circulation goals and what we're going to do for those. And so to kick in and be worried about our circulation status, it's a systolic less than 90 and signs of shock. And so why is it both of those at the same time? Well, we all remember that there are some patients who their SPPs are just on that low side, right? Your end-stage cancer patient who's emaciated, your end-stage liver or end-stage, dialysis type patient. All those, you may see like records at their bedside for the last 3 weeks and their blood pressure's been hanging out in the 80s, over 40s, and that's just them, right? So they may be awake, they're well perfused, they're pink, they got great cup refill, they're mentating well. All those type of things lend you away from the, I need to do a bunch of stuff just to make a number look pretty in this situation. So that's why we include the signs of shock and the SPP together. That way we're not just, fighting numbers, we're actually appropriately addressing bad perfusion and bad circulation in this. So here's our signs of shock here, right? So pale, cool, diaphoretic, modeling, kind of that splotchy skin, poor cap refill, thready pulses, maybe we lost the radial and only we're getting a thready carotid now for really bad hypotension. New onset ultramental status we've addressed before, they can't follow commands. All those are red flags that not only the patient is not getting good perfusion, but we're not perfusing the brain as well. Our first question for circulation, oftentimes this is a quick one and we move on, is this shock due to a dysrhythmia. And so the first ones are, is this an unstable bradycardia or is this an unstable tachycardia? And so I want to remind us all that, you know, heart rates in the 140s, 150s, particularly if they're sinus tachycardia or they're atrial fibrillation with rapid ventricular response or AFib-RVR, then those are rarely the primary cause of that patient's shock, right? A patient who is always in AFib and is kicked into AFib-RVR, that's basically just their sinus tachycardia. And so while that may be an arrhythmia, that may not necessarily be a dysrhythmia to the point where they're qualified for an unstable tachycardia. And so what we really need to think about is this a symptom or is this the problem, right? Is this patient septic and their elevated heart rate is a symptom or a sign of that underlying problem, or is this heart rate the actual underlying cause for that patient being in shock? And so sometimes this can be a little bit more subtle, right? And so we need to search for that underlying cause and dig for it a little bit more. That may be that extra 1 or 2 questions, right? Hey, have you been eating and drinking okay? Have you been vomiting or had diarrhea? Have you been vomiting any blood? Have you had any bloody stools or dark, tarry, sticky stools, right? All those questions may lead you towards maybe this is a bleed, or they're just profoundly dehydrated and their heart rate's so high. All those type of things will lead that way. The other part of that is maybe from a physical exam, right? Your nursing home patient who's nice and tucked in bed and the sheets are up to their neck, uncover them. Maybe that may be the sacral decubitus ulcer that's rotting away that's now caused them to go septic. If we hadn't evaluated that, we wouldn't have caught that and we would have thought that the heart rate was actually the problem here. And so just take that pause, think about, is this a symptom or is this the actual problem when we're thinking about heart rates, especially on the high side. But don't let that discourage you from moving forward if you need to. So if the patient's clearly in ventricular tachycardia or their heart rate's 230 beats per minute, right? That's pretty obvious that this is something that is probably an unstable tachycardia. So don't hesitate to light them up and sync cardioverter for the appropriate circumstance there. Let's move on to unstable bradycardia now. So atropine is not the answer, right? Unless you have an IV in place and a good reason that you think atropine is going to work for that patient immediately, these patients deserve to be paced, right? So many conditions don't respond to atropine, or if they do respond, it's a very transient or short-lived response, and we're right back in the same situation again. And so unless you have a good reason, we should move on to pacing immediately for these unstable bradycardia patients. And so we're all pretty good about knowing our current and our rate. So it's 30 milliamps, rate is 70. And so where we sometimes fall into the trap is that we slowly titrate up our current or our milliamperage, and we get a delay in getting capture. And so what you want to do is rapidly titrate up your current. This is not a 1, 2, 3 minute type process. This is, pressing the button, no, I don't have capture, pressing the button, advancing, pressing the button, getting to your higher energy levels until you have proven that you got capture. We're basically proving to ourselves, am I going to be able to pace this patient or am I not? And doing that in a quick fashion and also maxing it out to the max level you can is going to be the key to figuring this situation out quickly. And so also be aware that while we start at 30 because if you're the one being paced, you don't want to be at your max right off the bat if you could have had anything less than that. But quite oftentimes we're not going to get capture in the 50 or 60 or 70 milliamp range. And so be cognizant of that, and you may need to advance to those higher levels quickly to establish pacing. Also, don't forget to do your anterior and posterior pad placement. If your patient's super sweaty, super hairy or something like that, maybe you need to consider applying the pads, verifying that you're getting a good stick, and then applying a new set of pads if you need to. So if I've started pacing and I've gotten my first set of blood pressure and they're still hypotensive, the first question you should ask yourself is, am I getting capture or am I not? And so am I seeing a spike and then a left bundle branch block, and then another spike, and a left bundle branch block type pattern or not. And so if I'm getting a spike and maybe one good wave, and then I'm seeing a bunch of that underlying like cardiac activity, and then another one, and it's not really adding up to 70, then that is probably not capture. And so you probably need to go up in your milliamps or move on to the next steps. And so make sure you got capture right off the bat. Also, troubleshoot through. If you have had no capture and you're starting to advance up into your really high milliamp ranges, think about two things, tox and metabolic. And so think about toxicology. And so that's going to be typically your tricyclic or TCA overdoses, beta blocker overdoses, calcium channel blocker overdoses, or even your digitalis or digoxin type overdoses as well. And so be cognizant of those, think about them, check the meds, check if that's going to be the appropriate given situation, and move on to the specific treatments for those if you can. And so the other part of that is metabolic. And so when we talk about metabolic, what does that mean? So this is going to be your acidosis patient, right? So they're severely acidotic, the heart is not functioning and capturing electricity as appropriate. That will oftentimes be at some of your really high milliamperage ranges that you're getting capture for that. The other one is, your dialysis patient, right? Fistula in the arm, catheter in the chest. Take those context clues into point. Maybe they missed a dialysis session, and the hyperkalemia type part of this is going to, again, prevent you from getting good capture due to the dysfunction of all the cellular level type stuff in the heart. So if I started pacing, I've verified that I've gotten capture, and the patient is still hypotensive, my next move is going to be to increase the rate. And so this is the simplest and easiest thing we can do next, just pressing the buttons on the monitor, and we can crank that rate up and get a little extra cardiac output. And so remember that cardiac output is stroke volume times heart rate. And so stroke volume times heart rate, if we want to increase the heart rate, we're going to get increased cardiac output then. And so we want to crank that rate up a little bit, and that will help us get a little bit more perfusion there. But be mindful that a lot of these patients are these MI patients who, knocked off their bundle branches and now are requiring to be paced. And so we don't want to increase the, demand on the heart too much by cranking the rate up to, say 120, 130 just to get a good blood pressure, because now we're harming the heart and asking it to do a little too much. So if I've either failed to capture, I basically have maxed out my milliamps, I'm still not even verifying capture, or I've messed with the rate, I've verified I've gotten capture, and I'm still hypotensive, the next part of this is to move on to your epinephrine. This is probably the single biggest error we see when choosing a pressor, is choosing norepi over epi. And so that makes a lot of sense, right? It's the first one that we have on the trucks, the first one that we think about in our mind, and is also the most common that we use. And so utilizing epinephrine has significant benefits over norepinephrine though. And so epinephrine has inotropy, which is basically going to be increasing the squeeze of the heart, and also has chronotropy. And so if the heart and its native underlying electrical rhythms can react to the epi still, it can kick up the heart rate a little bit and give a little bit more oomph. Norepi, however, only squeezes the pipes down. And so if I lose the chronotropy and the inotropy effects by choosing norepi, I'm not doing the best for the patient. I'm not getting the best juice for my squeeze there. And so choose epi when using electricity is kind of your stupid mnemonic to remember this. So E for electricity. Also, we're getting much more aggressive with our epi with this. And so starting at 5 micrograms per minute, no more of this little tincture or sprinkle of epinephrine. We're starting at a good and aggressive dose. Don't fear starting at a dose that high though. This is going to be a safe dose for a vast majority of our patients, and quite frankly is the dose where I'm starting in the emergency department most of the time when I do it. And so we're not going to make heads explode by starting a little bit more aggressive, but we may get a better increase in our blood pressure in a quicker time frame and be able to move things forward and get the patient extricated and transported in a little bit quicker fashion, starting a little bit more aggressively and titrating a little bit more aggressively, as we'll talk about in a second. All right, at this point we've asked ourselves, is this a dysrhythmia or not? And we've either corrected that dysrhythmia or said, no, it's something else. And so this is where we fall into these other two categories. General medical, of course, is going to be the overwhelming majority of our patients. And then there's a little bit more rare of a category, the cardiogenic shock type picture. And so cardiogenic shock, we have to oftentimes have a little bit of trouble defining who fits into that category, who is this patient that we're thinking about for that. So for cardiogenic shock, the number one cause I want you to think about is an acute MI. And that acute MI is going to cause left ventricular failure. So this is your left anterior descending artery or widowmaker type MI that has knocked out the anterior wall of the heart, and now they're having pump failure. And so when you have pump failure, I want you to think of two things. First, it's going to backflow, right? And then it's also not going to flow forward very well. And so this causes two different things in the body. First, it's going to cause congestion, and it's also going to cause low perfusion. When you do our physical exams, these are the type of things we're going to find. So for congestion, it's going to be JVD, rales in the lungs, they're very edematous, they may not be able to lay flat because they're orthopnic and need to sit up. And then there is also the low perfusion part of this, right? So they are locked down. This is going to be a cold shock type picture. They're not going to be very warm and well perfused, they're going to be very cold and clamped down. And so we're going to find cold extremities. As we talked about earlier, cardiac output is stroke volume times heart rate. So if the stroke volume is bad, they're going to try and compensate by a higher heart rate. They're often quite tachycardic. And so you also may see poor cap refill or very weak pulses in the distal extremities. And so taking all three of these things into context, the full picture, it's going to be oftentimes your MI patient, they're going to look congestion, and they're also going to have low perfusion type picture. And so if all three of those things are together, that's often going to be your cardiogenic shock type patient. Cardiogenic shock patients are not, however, just that patient who is probably more like septic, but they look congested, where we need to restrict a ton of fluid volume on them and not, fluid resuscitate them just because they look fluid overloaded, right? Take the full picture into account when you think of these things to make sure that we're choosing our appropriate therapy for them. For general medical, we're much more comfortable in this category, of course, right? So this is your septic patient, the fluid loss, they've been puking for days, your anaphylaxis type picture. We're much more comfortable with this type of thing. And so this is going to be a preload or basically a tank problem or a pipe problem where they're all dilated out and they don't have the vascular clamp down that they should. And so these are going to be our most common type of causes for your general medical. When we think about our fluid resuscitation for these type of patients, for cardiogenic shock, we just talked about that they're already congested and fluid overloaded. So the idea that we're going to pour a ton of fluid on them and make them better is pretty far-fetched. And so we're going to start with a 500 ml or a 250 ml bolus as basically a fluid challenge. And so maybe they do respond. Maybe this is an inferior MI who just needs a little extra preload support and they bounce their blood pressure up. But many times we're going to try that fluid bolus and nothing's going to happen and they're going to fail that challenge. And so the idea that we're going to repeat to 2 liters, that's what the current protocol says. We're going to nix that in the upcoming protocols and basically favor a quick bolus and then move on to advanced measures if we need to there. And so general medical, of course, we got to fill the tank for most of these people. And so 20 ml per kilo bolus is we're used to. And then if there's an incomplete response, repeat and reassess up to those 2 liters and continue your fluid resuscitation up to those full 2 liters. And so they're going to benefit from a more aggressive fluid resuscitation for most people, okay? So most people, even the overloaded chronic CHF or chronic dialysis type patient, most of these can at least tolerate 500 mLs of fluid, if not more. And so make sure you're adequately fluid resuscitating them before you decide to move on to a pressor type situation. That being said though, be really cognizant that fluid responsiveness is variable by condition and your patient, right? And so if I give them a full liter and their blood pressure goes from 70/40 down to 50/30, then that's not really a great trajectory on that patient. I probably need to move on to an earlier pressor, even if I choose to continue my fluid resuscitation after I started my pressor in that situation. So essentially remember when to fold them, but don't go too early right off the bat where we haven't primed the pump or filled the tank enough for those pressors to be effective. But if we've done either of these type of situations and the SBP remains less than 90, that's where we're going to start norepi. And so we're going to start norepi just like epinephrine at 5 micrograms per minute. That's again a protocol change that you can start immediately. And so the norepi starting at 5 mics again is a more aggressive starting dose and is very frequently the starting dose in the emergency departments. So we're going to get a little aggressive here. So this is also a reminder that anaphylaxis is kind of the red herring in all this, right? This is where we're going to start early epi, way up as soon as we recognize that this is a severe anaphylaxis type picture. Starting epi to treat the anaphylaxis as a treatment, not just as a vasopressor like we're doing for all these other type pictures. Let's talk about IV attempts a little bit. So the protocol does not say anything specifically about you must do 2 or 3 attempts on IVs and immediately go to interosseous access, because we obviously know that some patients are going to take 3 or 4 IV attempts, and that's probably appropriate for some of those. But where we need to draw the line though is, if we have, multiple providers in the room all trying multiple different IV attempts and we still haven't gained access and, it's 40 minutes into this case, that's not using our currency appropriately, right? We are not moving that patient's care forward. So if we're spending 40 minutes and we haven't even gotten a drop of fluid resuscitation on that patient, that is kind of spinning our wheels and not moving things forward. And so we should be thinking about whether we need to move on to a different kind of access at that point. So that's going to be your interosseous access. And so you got to ask yourself when you're placing your interosseous access, why am I placing this in the first place? And so a tibial IO may be perfectly fine if you needed to follow up, a smaller gauge IV in the hand with, something to just give additional medications through, right? You just need a dedicated line to put your norepi or epi on, but you got something that'll flow some fluids through. But if they're that scarred up dialysis patient who have no hope for access in any of their extremities, consider doing a humeral IO in that situation, right? You need to give a good bit of fluid. That is your lifeline. That's going to be probably your single access point. And so you want something with a better flow rate than a tibial IO so we can adequately and rapidly resuscitate that patient. When we think about flow rates, here's our chart. So this is wanting to give you a kind of good sense of what we're getting for each of our gauges and device types here. And so the key part of this is the with pressure component. And so these are probably your max flow rates you're going to get if you're applying pressure. So this is 300 millimeters of mercury or a level 1 effuser. So the first teaching point from this is that if you're gravity feeding your fluids, your rates are probably half the ones you see on the screen there. And so if we're dropping in fluids and we've only given a liter over an hour or an hour and a half, that's not a good use of our time. So whether you're manually pressure bagging in the fluid or you're using a blood pressure cuff, consider using pressure on your fluids to get them in quickly and assess whether you need to move on to a pressor or not. And so the second learning point from this slide is that, some access is better than no access a lot of the time. And so if you're between that 20 and the 18 gauge there, if you think you can really, with high certainty, get to 20, you're only losing a few minutes in there. And so getting just some access is probably better than going big or going home in that case. The other part of this is your tibial and your humeral IOs on your slide. And so remember that humeral IOs are going to give you a flow rate probably about double your tibial, probably somewhere in that 60 to 80 ml per range. And so be cognizant of that when you're selecting your interosseous access, particularly for your medical patients that need fluid resuscitation or for some of your trauma patients where you need to fluid resuscitate as well. Don't fear the IO in your awake patients. Yes, it is painful. Yes, it is more invasive than an interosseous line, but we have tools, and if in the right circumstance they need it, let's do it. And so don't forget about your lidocaine infusion for this. And so the pigtail that you use for your IO needle, if you prime that with your 40 milligrams of lidocaine, that will take up almost about the entire pigtail there. And when it's infusing, that'll be the first thing that contacts that patient. So if you prime your line with saline and then you're giving your lidocaine, what's contacting bone first? Saline instead of lidocaine. And so you want to prime your line with lidocaine first. That way it can anesthetize that bone as best possible and make your patient more comfortable. Remember to push this slowly, just a small bit over, a minute or two, and then let it dwell for about 15 seconds. And then we want to move on to your flush. And so with these IOs, no flush equals no flow. This is oftentimes the most painful part, but once we've broken up the bone marrow there, we can get really good flow on these IOs, but you have to flush it to get that flow. Occasionally, when we get calls on OLPG, we have, medics who are very certain that they have gotten their IO in the correct place, right? We aren't concerned that it's outside the bone marrow cavity and we're going to infiltrate, and they're still not getting good flow or any flow at all. And so sometimes 10 cc flush is just not enough. So take a 30 or a 60 cc luer lock syringe, draw up some fluid out of, your IV line, and then do a really hard flush on that, and that will oftentimes break up that bone marrow cavity a little bit more and give you a better flow rate there. So those are your tips for intraosseous access. Pressors. Particularly for the MedStar medics, you gotta be a pump master. So these are, situations where we need pressors quickly and we wanna be able to efficiently set up the pump. And so if you're one of those that, has not set up the pump in a while, or you're uncomfortable with the pump, reach out to us, reach out to an FTO, practice your pumps on your shift, go through, your calculations and setup and all those type of things. We want to be ready. We want to be able to set up the pump in a timely fashion, goal less than 5 minutes or less. And so we got to practice and we've got to be masters at the pump. We recognize that the pumps can be finicky at times, and in next year's capital cycle, we hope to, get new pumps that may be a little bit more user-friendly, but unfortunately, what we got is what we got right now, and we need to be efficient and proficient at those pumps. As we talked about already, we're going to start at 5 mics per min, a little bit more aggressive starting dose right off the bat. And then we're going to aggressively titrate these pressors after we initiate it, right? So this isn't a goal of moving up a couple micrograms, every 10, 15 minutes, right? So probably every, 5 or less minutes, we're going to start bumping up that pressor a little bit more. We're not going for ICU level dialing in of that pressor, and getting it exact. Again, we're not going to make heads explode. You may get a blood pressure occasionally that's a little bit high. That's very, very easy to correct. We can back down that pressor a little bit. But most of the time we undershoot our pressors, and it takes us way longer to titrate them up to get us to the appropriate blood pressure, rather than the opposite where we go too big right off the bat. And so in the next protocol revision, we're considering adding higher titration parameters, something probably in the 25 mic to 30 mic range. We've gotten a lot of OLPG calls from some really heads-up crews that have already maxed out their 10 of norepi and are looking to go further. And so if we keep on granting those same orders over and over, our idea and our philosophy is that we'll just bring that down into the protocol to allow for y'all to be able to do the most aggressive care you can for your patients possible. Also, don't forget about a carrier fluid or kind of a piggyback fluid as well. And so what you'll have is your initial line from your fluids coming in, and that'll be hooked up to your access, and then you're gonna Y in your pump as well. And so particularly at some of these small pump or pressor doses, you're only infusing just a small ml or even fractions of an ml per minute. And so if you haven't completely primed your pressor line all the way, it takes a second for that to flush out all that saline and actually reach the patient and get into their circulation. So the idea behind priming all of your tubing and then having a carrier fluid come in as well is going to help you make your patient receive that pressor much quicker in total. And so once every little drop of pressor comes in, that carrier fluid is taking it to your patient. And so occasionally we see delays in basically the response to pressors, and this is oftentimes the situation is we're either not using a carrier fluid or we haven't fully primed our line all the way there. Don't stop just because of a pump failure, okay? Some of these patients need pressors like yesterday, and so this is oftentimes where OLPG is going to come into play, and you're going to call for a dial-a-flow. And so Many of us on OLPG already have a pre-calculated set where we can dial in your dial flow and get the appropriate pressor rate for you. And so don't hesitate to call OLPG if you're in a situation where you need a pressor right now and your pump has failed or is malfunctional or something like that. If you have a little bit more time, consider asking for a second MedStar unit. And so asking for that second unit can deliver a pump. We've had a few cases of pump failure where we've asked for the second unit, and usually we've been in a pretty good situation overall on that. Back up, Levi. Also, in a pump failure situation, don't stop, right? Some of these patients will need pressors like yesterday, and we need to be able to deliver them to the patient. So, of course, you can always ask for a second unit. We recognize that, occasionally the system is going to be taxed in level 0, and they may not be able to arrive in a quick time frame where your patient doesn't have, even the 5 to 7 minutes for that unit to respond. And so the other option for you is called OLPG. We have pre-calculated charts to basically guide you through a dial flow setup and setting in your pressor rate as appropriate there. And so we can definitely help you out in that way. Don't stop, don't just, fold them and, start loading a critically hypotensive patient just because the pump is not cooperating, it failed, or some other, catastrophic equipment type thing is going on. We got options for you out there to start the pressors you need to. Or after all of those other considerations, you've literally just, had a respiratory patient who, a COPD who you correct the respiratory part, they never had anything problem with their circulatory status, you correct a respiratory type goal, and then you rapidly progress through their circulatory with an SPP greater than 90, and so you pass. And so that's the patient where, we're gonna rapidly progress through, address what we need to, and move on. And so the idea is not to belabor this protocol and do a bunch of things we don't have to. So here's our circulatory goals again, right? SPP greater than 90, or we've initiated vasopressors as our exit strategy. Once we've addressed those, also consider, is there an improvement in my blood pressure? Is there an improvement in my mental status? Is there better perfusion, right? So more objective markers that I'm actually improving my circulation based on the things that I'm doing. So take those into consideration besides just the goals themselves. Once we've addressed our respiratory goal and our circulation goal, at this point, it's okay to initiate movement or extricate. Not necessarily transport just yet, but we can definitely get that patient out of the situation, out of the house or wherever we found them, extricate them and move them to the ambulance at this point, right? So check, 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 we've gotten our goals done and we're gonna move on. But there is a difference between can and should. And so that's a critical concept I wanna convey still. So just because we may have met those goals doesn't necessarily mean we should move every single patient who has met those goals, particularly the ones who have gone into the exit strategy type thing. So the first one I want us to think about is very critical hypotension, right? So a blood pressure of 50/30 that you just initiated vasopressors on, yes, they've met the goal. However, it may very well be worth it to take those extra 10, 15 minutes to aggressively and rapidly titrate that pressure up, get a much more adequate blood pressure, something 80/40, or even meet your nut goal of 90 for a much more safe move, right? A 50/30 is still very dangerously close to a PEA arrest for your patient there. So spend just a little bit more time to rapidly titrate and get that patient safe. The other one is that tenuous airway. And so what do we mean by a tenuous airway? So that is the patient who is, being bagged, you have all your adjuncts into place, you've had to get the absolute best seal possible, they're at a really high PEEP, and you've gotten their oxygen to 94%, right? So you've met your goal, but you are working incredibly hard to maintain that goal. Particularly, if every time you lose seal, they plummet their sats down into the 80s really quickly. Like they have no reserve, they can't compensate even from a minor deviation in excellent BVM ventilation. That patient, especially if you're having to go down a sidewalk, past 5 cars, down rocks, and down a couple stairs, that's probably not a patient where you should move without addressing the airway a little bit further in that situation. That way we can maintain the gains we've made and ensure that they're going to be maintained throughout the extrication process. Also, ask yourself, have I actually established a trend in vital signs to feel confident in my efforts? So this basically goes back to that a single set of vital signs is a single set of vital signs and does not establish a trend. Just because I saw SpO2 of 94% or a blood pressure at 91 and flash up on my monitor doesn't mean that I should 100% trust that I've gotten that single number once, right? We want to establish that we feel good, that this patient is on the up and up, or I've gotten some measures in place where I can keep them stable to get them to the truck in that process, right? So don't just go off of numbers, take the full picture of where the patient is going into play. So at this point, we've either gotten into the truck or we've decided to just maximize our therapies a little bit more on scene. This is where we're looking to quickly wrap things up, right? We've done all the hard work at the point of contact for this patient, and now we're looking to just titrate our interventions. You know, maybe I started a pressor and I need to start that 2nd liter of fluid. Maybe I just need to give magnesium to that patient, or I already started on CPAP and did all my asthma COPD treatments already. The idea is to just put a bow on top. Quickly get things done, start moving to your destination after that, but maximize our protocols out. Now let's talk about drug-assisted airways and intubation a little bit more. So we specifically did not say you must intubate on scene or must intubate in the truck. So this is where critical thinking comes into play and goes back to that can and should discussion a second ago. So the patient who has that tenuous airway, absolutely you probably should move forward with that on scene to ensure that you have secured your efforts appropriately. And so, but that patient who is easy to bag, I've gotten great end-tidal CO2 the entire case, maybe that is the patient, it's totally okay to go to the truck for it, right? There's advantages to the truck. Well lit, we have 360-degree access on them. I got a stretcher where I can put the head of the bed elevated on them, right? I have the power suction over there. You know, all those type of things are certainly advantages to have a nice controlled environment in the truck for that. But of course, we can't always get that controlled environment for some of our patients there. And so this is a very much of a judgment call or a critical decision making of where we're doing that airway. The other part about that is we talked about that we have to resuscitate to intubate. And so we may have met our goal of initiating a vasopressor, or we've gotten our SBP to greater than 90. But remember your shock index. And shock index is heart rate over blood pressure again. And so if we're looking at our shock index, if our heart rate is 140 and I just started pressors, or I haven't met my SBP of 90, that's a stupidly high shock index at that point. And so a shock index greater than 1, especially if it's getting in the 2, 3, 4 range, increases your risk of post-intubation hypotension or after intubation cardiac arrest. And so be aware of those things, and that you need to be cognizant as you're going through for a drug-assisted airway, particularly where I'm at in my resuscitative efforts. And so our goals for a drug-assisted airway are very similar to our crush and patient goals, right? An SBP greater than 94%, an SBP greater than 90. But for that patient who needs a little extra oomph, consider that you may need to make that blood pressure as good as possible, right? So that patient may need to, push that blood pressure up to, a 110 range. That way, when I push my ketamine, chill that patient out, and they lose some of that sympathetic drive and their blood pressure settles down a little bit, they may only follow from 110 down to about 95 instead of going from maybe 90 to 80 or even 75. And so this is very much a good offense is a very good defense in this situation. So be cognizant of those things. We want our drug-assisted airways to be the safest possible, especially getting good fundamentals moving forward when we consider in the future possibly adding RSI. The last point on this part is we may occasionally push our drugs and then we get a lower SBP reading. And so this is where sometimes we just abandon all efforts, and that's not really what we're looking for here, right? Particularly if you're already bagging a patient. If you push the drugs and then their blood pressure falls, that may be a side effect of that medication, but that doesn't mean, oh no, I've met my goal, I haven't met my goal now, I can't intubate. You've already kind of committed the patient to that procedure at that point, so go ahead and intubate and get the job done. That way we can get the blood pressure up simultaneously and have a secure airway. That being said, though, if your SPP all of a sudden precipitously drops, that is a dangerous airway at that point, and we probably should consider, do we need to optimize that patient further and then move forward with your intubation. So that's a delayed intubation where we get our oxygenation up and then do a safe intubation. Let's keep in mind our goal for the entire thing. We talked about a bunch of the nitty-gritty type things, but this is our overall goal, right? We're simply just providing our best attempts at stabilization for a safe movement and transport to the ED. That's it, right? So we're doing the minimum amount of efforts that we can get to that patient safely to the hospital. This is not prolonged field care. We're not looking to exhaust 4 or 5 oxygen bottles and half a bag of norepi on scene and set up basically a critical care environment in grandma's living room, right? We're basically just getting the exit strategies or our goals in order so we can move that patient forward. The goal is not to make a perfect blood pressure or a perfect SAP all the time and get 100% resuscitation so the patient can go home from the emergency department. We're just getting them safely from point A to point B with our resuscitative efforts. So at this point, it's time to burn out. It's okay to go to the hospital, get us transported, and get that benefit in the emergency department, okay? But be cognizant, once we started transporting, we want to push to the finish line. It makes a lot of sense that once we get into the truck, right, we all take that big and relax and kind of let our guard down a little bit. Maybe we just did our drug-assisted airway in the truck and then started moving, right? We just pushed some drugs and that blood pressure is gonna, sag a little bit during transport. We're also trying to call a report. Maybe we're trying to get a little bit of charting done. Maybe, it's a solo med-star paramedic in the back at that point, no fire riders, all those type of things. Let our guard down, and we may not be as cognizant as we sag those blood pressures or lose a little bit of ground on that resuscitation. And so be sure to be vigilant and don't lose those opportunities to maximize our therapy and maximize our resuscitation so we can provide the best patient package, the best resuscitated patient we can once we arrive at the emergency department. Don't forget also, you can always call OPG if you need a little extra of something that's not in the protocol, and we can help you further resuscitate that patient. And so in total, just push to the finish line and get your patient there safely. All right. We basically covered all the protocol at this point. So this is crashing patient medical in a nutshell in your protocol here. As always, any questions, concerns, or anything that we can clarify, please reach out to the OMD. We're happy to help and clarify anything or help us work through these as a team and as a system together. And so thank you for your attention, and I'll see you next time.